In Khundukar, today we will talk about Guillain-Barré syndrome. As a quick recap about Guillain-Barré syndrome, the pathophysiology is immune-mediated demyelination polyneuropathy, preceding mostly by gastrointestinal infection, mostly by Campylobacter jejuni bacteria, or respiratory infection, either cytomegalovirus or Epstein-Barr virus. Clinical features, as we said, is polyneuropathy can be presented as paresthesia, neuropathic pain, symmetrical ascending weakness, and decreased or absent deep tendon reflex, autonomic dysfunction like arrhythmia or ileus, respiratory compromise. We will diagnose Guillain-Barré syndrome by clinically or supportive finding like LP. When we analyze the cerebrospinal fluid, show increasing protein amount and normal leukocyte. When we do EMG, there is abnormal in electromyography on the nerve conductive study. In MRI, could be normal or enhancement of anterior nerve root like coda equina. Management monitoring of autonomic and respiratory function and we do intravenous immunoglobulin or plasmapheresis.
34-year-old man comes to the emergency department due to progressive leg weakness for the past several days. He also reports a tingling sensation in the toes and mild low back pain. 3 weeks ago, the patient was evaluated for flu-like illness, oral ulcer, and lymphadenopathy and was diagnosed with HIV infection. He has not started antiretroviral therapy yet while waiting for drug resistance testing results. Temperature is 37 C, 98.6 F, blood pressure is 120/70ths of a millimeter Hg, and pulse is 72 per minute. Lower extremity examination shows marked muscle weakness and loss of deep tendon reflexes bilaterally. Touch, pain, and vibration sensations are intact. Upper extremity examination shows no abnormality. There is no focal back tenderness and no signs of meningeal irritation are present. Which of the following would be most helpful in revealing the cause of this patient's weakness?
Okay, this patient was recently diagnosed with acute HIV infection, flu-like symptoms, lymphoadenopathy, oral ulcer, now has progressive lower extremity weakness with absent deep tendon reflex. This is considered with Guillain-Barré syndrome. GBS is often preceded by an acute infection, as we said, Campylobacter jejuni or cytomegalovirus, or either acute HIV. It may be caused by immune response that cross-react mimicular mimicry with a peripheral nerve component like a myelin sheath. Also, the gastrointestinal and respiratory infection are most commonly incomplete. Acute HIV infection can also triggering GBS. In patients with HIV, GBS most commonly occur prior to the onset of AIDS and can be the initial HIV presentation. Can the patients with HIV presented with GBS? This clinical presentation of HIV association indistinguishable from non-HIV associated GBS. Patients have ascending motor deficit, hyporeflexia, and low back pain. Sensation is classically unaffected. Diagnosis is based on clinical finding, cerebrospinal fluid analysis, and nerve conductive study, which relieve evidence of demyelination on AMG, decreased motor nerve conductive velocity. The HIV testing should be also preferred. Okay, let's analyze the choice together. Cerebral spinal fluid PCR Viral meningitis is classically presenting with fever, headache, vomiting, and neck rigidity. In CT scan is CT scan of the head. CT scan of the head can detect a mass lesion in the brain, which may occurring in immune suppressed patients due to opportunistic infection or AIDS association tumor. In addition, hyperreflexia, upper motor neuron sign, rather than absent reflex like this case, would be expected. Choice D, toxoplasma serology, uh, toxoplasmic encephalopathy, which is can occurring with the CD4 account less than 100, typically also presented with fever, headache, confusion, and seizure. A tuberculin skin test. HIV is increased risk of tuberculosis, presenting of subacutely with fever, headache, and neck rigidity. As a home message, the Guillain-Barré syndrome is an immune-mediated polyneuropathy, can be associated with the early HIV infection. The clinical presentation and diagnosed workup of HIV-associated Guillain-Barré syndrome is the same as non-HIV-associated GBS. Nerve conductive study showing demyelination can help confirm the diagnosis. In the end, I hope you enjoy and thank for listening.